Hello students, welcome to Chapter 10. This chapter focuses on eating disorders. And the main ones are anorexia nervosa, bulimia nervosa, and binge eating disorder. And these eating disorders have dramatically increased as thinness has become a national obsession. In anorexia nervosa, an individual purposefully takes in too little nourishment that results in low body weight, lower than people who are of similar age and gender. They are very fearful of gaining weight, or they repeatedly seek to prevent weight gain despite the low body weight. They also have distorted body perceptions and place inappropriate emphasis on weight or shape in judgments of themselves, or they fail to appreciate the serious implications of the low weight. There are two main subtypes: the restricting type, where individuals lose weight by cutting out sweets and fattening snacks, eventually eliminating nearly all food. And then these individuals show almost no variability in diet. The binge eating and purging type shows individuals losing weight by forcing themselves to vomit after meals or by abusing laxatives or diuretics, and they may engage in eating binges as well. The incidence of anorexia is 75%, occurring in females. Approximately 0.6 of all people in Western countries experience anorexia. The peak onset age between 14 and 20 years is seen for this disorder. In terms of the clinical picture, the key goal for sufferers is to become thin. They're motivated by fear. They have a strong preoccupation with food and distorted thoughts, and then a low opinion of their body shape. They tend to overestimate their actual proportions and hold maladaptive attitudes and misperceptions. Potential psychological problems that can coexist include depression, anxiety, low self-esteem, and sleep disturbances, substance abuse, and obsessive-compulsive patterns and perfectionism. And that perfectionism sort of translates into those very stringent ideas about what their body should look like. In terms of medical problems that coexist with anorexia, we see amenorrhea, or lack of menstruation. We see lower body temperature, low blood pressure, body swelling, reduced bone mineral density, and slow heart rate, and metabolic and electrolyte imbalances. Also, there are skin, nail, and hair problems due to lack of nutrition. Bulimia is the second major category of eating disorder, bulimia nervosa. This is where people repeatedly binge eat, and there is repeated performance of ill-advised compensatory behaviors such as forced vomiting to prevent weight gain. Symptoms take place at least weekly for a period of 3 months, and there is inappropriate influence of weight and shape on appraisal of oneself. About 1% of the population develop bulimia in their lifetime. 75% are females. 5% of adolescent girls develop the full syndrome, and there's a high rate among college students. The progression of bulimia goes from normal to slightly overweight. Female has been on an intense diet. It begins in adolescence or young adulthood, lasts for years with periodic let-ups, and weight fluctuates but often stays within the normal range. Binges in bulimia are episodes of uncontrollable eating during which a person ingests a very large quantity of food. It may involve 1 to 30 episodes a week and 2,000 to 3,400 calories per episode. It's often carried out in secret, usually with sweet, high-calorie, soft-textured foods. Usually there's great tension before a binge, which is relieved by that eating. And then there's extreme self-blame, shame, guilt, depression, and weight gain fear. And so then the compensatory behaviors start, which involve vomiting and purging, laxatives and diuretic use. There are compensatory behaviors, effectiveness, meaning that some temporary positive effects are seen, and there's caloric binging effects, however, that are not undone. In terms of body dissatisfaction, it's the single most powerful contributor to dieting and the development of eating disorders. People who evaluate weight and shape negatively are experiencing body dissatisfaction. Approximately 83% of all girls and women are dissatisfied with their bodies, compared with 74% of boys and men. The vast majority of dissatisfied females believe they are overweight. Half of dissatisfied males consider themselves overweight, and half consider themselves underweight. Binge eating disorder is the next category that we're going to talk about. These are recurrent binge eating episodes that include at least 3 features of these: unusually fast eating, absence of hunger, uncomfortable fullness, secret eating due to sense of shame, and subsequent feelings of self-disgust, depression, or severe guilt. There's a lot of distress that comes with this. Binge eating episodes take place at least weekly over the course of 3 months, and there is an absence of excessive compensatory behaviors in this disorder. These repeated eating binges occur in which people feel no control over eating and do not engage in the compensatory behavior. It's around 2.8% of the population. At least 64% are female. There's a later age of onset for this disorder. As a result of frequent binges, half become overweight or even obese. There are many shared features with bulimia nervosa or anorexia nervosa, but not the same drive to thinness. So what causes eating disorders? The psychodynamic community talks about ego deficiencies, looking to disturbed mother-child interactions that lead to serious ego deficiencies in the child and severe perceptual disturbances. Children of ineffective parents become confused adults who are unaware of their internal needs. People with eating disorders inaccurately perceive internal cues, which is called alexithymia, and are more likely to worry about how they are viewed by others. The cognitive behavioral point of view states that several cognitive factors, such as improper labeling of internal sensations and needs, contribute to eating disorders. There is little control over life in some of these individuals that may result in excess control of body size. And this contributes to a broad cognitive distortion that lies at the center of disorder eating. For example, negative self-judgment based on body shape and weight. And personally, I have seen individuals that do have very controlling family environments, and so they do resort to eating disorders as a means of control. Depression helps set the stage for eating disorders. Many more people with eating disorder are diagnosed with major depressive disorder than in the normal population. Close relatives with eating disorders have higher rates of depressive disorder. Similar brain circuit abnormalities are involved in those with eating disorders and depression, and antidepressant drugs sometimes help persons with eating disorders. Biological factors come into play. Certain genes may cause susceptibility to eating disorders. Relatives of people with eating disorders are 6 times more likely to develop eating disorders themselves. And then that brain circuit dysfunction is linked to interconnectivity problems. In these brain regions, we do see brain circuit dysfunction, and there's a link there. Abnormal activity levels of serotonin, dopamine, and glutamate, those neurotransmitters, can also come into play. Societal pressures arguably are some of the most prominent reasons for eating disorders. Western standards for female attractiveness are pretty narrow. Society really has a prejudice against overweight people, and there are higher risks for eating disorders within certain subcultures, such as models, actors, dancers, and certain athletes. There are economic and racial differences in eating disorder prevalence rates as well. Social networking, internet activity, and television browsing all reinforce the emphasis on thinness. The family environment can also impact people and cause the development of these disorders. If there's a history of emphasis on thinness, appearances, or dieting and perfectionistic mothers, and enmeshed family patterns, lots of over-involvement or over-concern, that can produce eating problems. Multicultural factors are certainly worth mentioning as well. Prior to this century, the eating behaviors, values, and goals of women and minority groups in the U.S. were healthier than those of non-Hispanic white American women. There was lower concern with body weight and body shape dissatisfaction, more attainable body dimensions. But at this point, what we see is that over the past 2 decades, young women of color in the U.S. express body dissatisfaction to the same degree as young non-Hispanic white American women. And they're even more likely to engage in disordered eating behaviors, particularly binge eating. They may actually have a higher prevalence of eating disorders, including binge purge disorder. Treatment goals for eating disorders are to correct the eating patterns and address the broader psychological and situational factors that have led to and maintain the eating problem. Immediate aims of treatment for anorexia are to regain lost weight, recover from the malnourishment, and eat normally. And achieving lasting changes is most commonly accomplished with cognitive behavioral therapy. The identification of the core pathology, the thought processes, and alternative stress and problem-solving strategies produce results. Monitoring ties between feelings and hunger levels and food intake also benefits people suffering from these disorders. Changing attitudes about weight and eating, and creating more independence and control mechanisms can make a big difference. This is most successful when it's continued for at least a year beyond recovery and supplemented by other approaches. There's long-term success linked to overcoming underlying psychological problems as well. Combination of education, psychotherapy, and family therapy is used, also psychotropic drugs. It's more effective in anorexia nervosa than the other therapies. The most effective prevention is when it's continued beyond 1 year. Best results are when they are supplemented by other approaches, especially family therapy. Family therapy does change family interactions, usually for the better. It's a valuable treatment component, especially for children and adolescents, and involves the whole family, and it separates the feelings and needs of each individual from those of other family members. Treatments for bulimia nervosa are frequently offered in eating disorder clinics. They eliminate binge and purge patterns and establish good eating habits. They eliminate the underlying cause of bulimic patterns using a combination of therapies. There are programs that emphasize education and therapy and antidepressant drugs. Treatments emphasize cognitive behavioral therapy, things like diaries and exposure and response prevention therapies. The cognitive techniques help clients recognize and change maladaptive attitudes toward food, eating, weight, and shape. And they typically teach individuals to identify and challenge those negative thoughts that precede the urge to binge. Other forms of treatment include psychotherapy, such as interpersonal psychotherapy, psychodynamic, family, and antidepressant medications. All of these therapies may each be offered either in an individual or a group therapy format, aside from the medication component. Treatments for binge eating disorder are the reduction or elimination of binge eating patterns. Cognitive behavioral therapy and other forms of psychotherapy are used, along with antidepressants. There is a short-term effectiveness and high relapse risk, however, so additional weight management interventions are often needed. And this concludes my comments on Chapter 10.